Hello everyone. Good morning, good afternoon, and good evening, everyone. I'm Sabina Signal, one of the members of One Health Knowledge Cafe, and I will be moderating today's webinar. I'm delighted to welcome everyone to today's webinar. I take this opportunity to thank our speakers, Dr. Stephen Housen, Geneva Fernandez, and Gabriel Kohler for accepting our request to deliver the talk in today's webinar. So this webinar is being hosted by One Health Knowledge Cafe, talking about One Health Knowledge Cafe. One Health Knowledge Cafe is a collaborative effort of more than 11 individuals. So the members are from Asia, Africa, Europe, South America, and North America, and it aims to bring together the expertise and network of researchers and professionals from various discipline, countries, and expertise to enable cross-learning, sharing, and network building. So it has been organizing monthly webinars, and it also has been designing the online courses. So this is the seventh webinar being hosted by One Health Knowledge Cafe, and this is supported by LMU CIS through their exit program funded by BMZ. So I would like to highlight some of the housekeeping rules. I request everyone to keep yourself muted unless you are speaking, and keep your videos off if you are not presenting. The sessions will be recorded and shared. PowerPoint slides will be shared in our CIH website. We will have Q&A session at the end of all the presentation, and we encourage you to put your questions in the chat box. Any specific questions to particular presenter just for clarification is limited to 2 minutes for 2 questions. And in case of any interruption on the presenter due to internet, we will wait for a maximum of 2 minutes and move to the next presenter. So we have three presentation, and each presentation will have 10 to 12 minutes, and we will have question and answer sessions and discussion session at the end of all the three presentations. So with this, I am pleased to introduce our first speaker, Dr. Stephen Housen, who is by training a physician epidemiologist. He is currently on the faculty of School of Public Health at the University of Alberta. He is also the editor-in-chief of the journal Global Health Science and Practices. The focus of his work is community health system, maternal and child health, particularly in South Asia and Sub-Saharan Africa. Throughout his career, he has had a major preoccupation with the use of evidence, particularly evidence arising from program for improving program performance. So with this, I would like to hand over the floor to Dr. Stephen. Over to you.
Thank you, Sabina, and hello, everybody. Good evening, good afternoon, and good morning. I'll just get my screen going here. Let's see now. Okay, oops, get right back to the beginning here. Okay, so I hope that's displaying properly now. So in my talk today, I'm going to be reviewing what we know about what's driving propagation of the COVID epidemic. And here I have three main points, the three C's, which I'll explain in a minute: network levels and the importance of clusters. Second, I'll be talking about age and mortality risk. And then between region differences in mortality impact, and then finally implications for control strategy. And here I'm going to be addressing 4 points. What does it mean to be cautious? Tailoring strategy to context, considering impacts of control measures on non-COVID outcomes, and being strategic.
Excuse me, Stephen, we can't see your screen.
You can't see the screen. Okay, let's see. I'll try again. Okay. Are you seeing the screen now?
Yeah, we can see it now.
Okay, thanks then. So, so early on in the epidemic, the Japanese understood better than most of us what are the drivers of COVID spread. And they summarized this simply in their health messaging as San Mitsu, the three C's. If we want to avoid getting infected, we need to avoid prolonged close contact with no barrier preventing one person from breathing in what another person has just breathed out. We need to avoid tight, closed spaces. So for example, if you're together with other people in a vehicle, it really makes a difference whether or not the windows are open. And we need to avoid being together with multiple people who in turn are connected with multiple networks of other people. And from very early in the epidemic, determinations were made of the R naught for this pathogen, meaning for each new infection, on average, how many new secondary infections were arising. And as we've learned, this is important. If the average number of new cases is less than one, an outbreak will peter out. But if it's more than one, it will grow. However, different organisms with similar R naughts can produce spread that's smooth or lumpy. And I'm sorry about that. So by smooth spread, what I mean here is that if we have an R naught of about 1, most infected people will infect one more, some won't infect any, and a few will infect more than one. But with a pathogen producing lumpy spread, a phenomenon the statisticians call overdispersion, spread is disproportionately driven by a small proportion of infected cases. And this lumpiness or overdispersion is a characteristic of some pathogens, but we see this evident in other phenomena as well. Now, clustering of transmission or overdispersion is a characteristic of COVID, as it is with SARS, measles, and tuberculosis, although less so for influenza, which spreads more smoothly. For COVID, from available evidence, as few as 10 to 15% of cases may account for 60 to 70% or more of secondary infections. So what are the implications for control? First, we really need to be focusing on reducing super spreader conditions. And second, to the extent that we're doing contact tracing, we should be doing backwards contact tracing to identify source events and then follow up those exposed, as is practiced in Japan. This is more efficient than just forward contact tracing as practiced in most Western countries. Now, beyond these specific features of COVID epidemiology, in understanding spread, it's helpful to think about networks. With an infectious disease like COVID, the relevant networks are interconnected across multiple levels. So first, for a new pathogen to spread widely means it has to hop from country to country, region to region. So one of the control measures that's been used with varying degrees of success has been stricter border controls, screening people on entry, and requiring that new arrivals go into strict quarantine. Now, once a pathogen is circulating in the country, we talk about community spread. And it's here that super spreading events or conditions are so important. And finally, we have spread within networks at the household level or at the level of residence. Now, of course, many people have living arrangements that involve more people than just a nuclear family. And indeed, aggregate residences, such as migrant worker dormitories, constitute a really important kind of setting where there can be efficient networks of spread. Now, to change gears a bit, so first, what is infection fatality rate? What this means is of all people getting infected, whether or not they get a lab confirmed diagnosis, how many end up dying of the infection? Currently in Europe and North America, available evidence suggests that we're now seeing about 1 COVID attributable death for every 300 people infected. But an overall aggregate measure is rather misleading. As you see here, mortality risk among those infected varies enormously by age. For example, for those infected who are aged 50, they have about a one chance in 400 of dying. But for those aged 85, the risk is greater than 1 in 4. So what we're seeing here, this is the same data, but presented using a log scale. So here we see that we have an exponential or log linear relationship between age and fatality rate. And from about age 35 on, for every 18 additional years of age, the risk of death increases tenfold. Now let's look at how this may be relevant when we're thinking about control strategies in countries with old or young populations. What I'm showing here is the age distribution of Canada, where I live, and in India. Now, clearly, Canada has proportionately far more old people than India does. In Canada, more than 4% of the population is 80 or older, and in India, the proportion is less than a fifth of that. As we've seen, COVID infection is associated with low risk of death for young people, high risk for old people. So how might we expect the pandemic to play out in settings with few old people? And how about in settings with a lot of old people? What I'm showing here is daily mortality rates as were available last week. Down at the bottom in yellow, we have a number of countries in Europe and North America. Now, those that I'm showing here, daily mortality rates range from 2.5 up to 8.9 COVID deaths per million population per day. We also see in blue the two most populous countries in Latin America, Brazil and Mexico. Their mortality rates are in the same range as Europe and North America. In the top half of the figure, we see quite a different picture. Here we have COVID mortality rates for a number of countries in Africa, shown in green, and Asia, shown in red. And we see mortality rates in these regions ranging from lower than 0.01 deaths per million up at the top in Nigeria and Ghana to just under 2 per day in South Africa. The Asian countries included here show a somewhat tighter range from 0.07 per day in South Korea up to 0.5 per day in Indonesia and Nepal. Now, I should mention that there are other Asian countries that have substantially lower mortality rates than this, for example, in Vietnam and Thailand. Now here, I'm presenting this information a little differently. What I'm showing is the ratio of current COVID deaths to expected total deaths based on the most recent pre-COVID mortality data. And what this shows is that if you're living in a place like Belgium, down at the bottom, COVID really is a big deal from a mortality perspective. Currently, there's one COVID death in Belgium for every 3 deaths that would normally be expected over this period. In the top half of the figure, however, that is among the Asian countries shown and all the African countries except South Africa, the current number of COVID deaths is less than 3% of expected total mortality. And if we look just at the 5 countries at the top of the figure, the proportion is less than 1%. So there are huge differences between countries in how important a contribution COVID is making to overall mortality. I'd like to make the case that to develop sound strategy for whatever measures we're considering, we need to consider 3 points: possible benefits and possible harms, including who within the population is likely to be most affected. Second, feasibility and acceptability to the population. And third, what's the situation we're facing in our particular setting? Policymakers have been struggling. Some policymakers have been minimizing the threat, but many others have been making the mistake of focusing only on COVID, not taking into account collateral harms that could result from control efforts, and notably not giving sufficient attention to who is likely to be benefited and harmed by our control efforts. Now, that's understandable. It's part of human nature that we fixate on new and unfamiliar risks, and we discount or minimize familiar risks. Now, riding along on their bicycles, these 2 women face a small but real risk of head injury if they should be in an accident. But note, they're not wearing helmets. Now, you see they're wearing something else here. They're wearing masks. Now, but even without masks, they have 0 risk of picking up COVID out riding on their bikes. I suppose, however, that the masks do reduce the amount of dust that they breathe in. So We've looked at the data comparing across countries, and we've seen vastly different COVID-related mortality. In comparing across these groups of countries, we see important differences across several other dimensions. Just have a glance at these. Now, of course, it would be easier to have a single off-the-shelf solution for all settings, but that's not how it works. It would also be easier if there weren't trade-offs or collateral harms associated with the strategies that we're considering. But in fact, as we've seen, there are huge collateral harms. The World Bank is projecting that 150 million people will be pushed into absolute poverty as one of the indirect collateral harms associated with our response to COVID. Children around the world have lost significant time in schooling, and this has disproportionately affected the poor. Primary healthcare services have been undermined, with important impacts on malaria, HIV, TB, immunization preventable diseases, and child malnutrition. And again, this disproportionately affects the poor. We need to be focusing not only on COVID, but on this broader range of elements of health and well-being as we choose what to do. And we need to keep our eye particularly on those most likely to be harmed. We need surgical precision, not sledgehammers. Thank you.
Thank you so much, Dr. Stephen. There is a quick questions for you. Uh, the question is, could the lower mortality rates be related to how many deaths are recorded as COVID related?
I think there's no question any of these data that we have, like whether it's say cases or deaths, there's I would say there's lots of noise in the data. But I think the indicators that are being reported from country level, I think they at least give us a good general sense of what's happening in terms of order of magnitude. And comparing between these countries, like there are huge differences in mortality burden. And I think there's every reason to believe that those differences are real. Even if the actual point estimates on mortality in a given country have a certain amount of error in them.
Okay, thank you so much. Thank you so much for discussing on the different contextual strategies and highlighting the statistics on the different regions. So with this, I'm pleased to introduce our second speaker, Dr. Genevieve Fernandez. Dr. Genevieve Fernandez is a research fellow at the University of Edinburgh, where she supports partner organizations in advancing respiratory health outcomes in South Asia and leads a research team on international COVID-19 policy responses. Over the last 10 years, Genevieve has worked in public health research and program implementation projects on maternal and child health, HIV/AIDS, tobacco control, influenza A, and food security across states in India and in South Asia. Her academic background is in social sciences and public health, recently completing her doctoral research on the role of World Bank in maternal and child health over the last 4 decades. So we are excited to hear from you, Dr. Genevieve. Over to you.
Thank you, Sabina, and thank you, Stephen, for starting off on such a great note. I will just quickly try to share my slides right now. So just to start off, I work with a team of researchers under the leadership of Professor Devi Sridhar at the University of Edinburgh. And for the last 6 or 7 months, we've been doing a lot of COVID policy research. And all of this research is based on the needs of policymakers. So the discussion today that I've prepared here is really drawing from our work, and I'd like to thank my team for their inputs here. So I'm going to really focus on the health system resilience, and I'll try to unpack this concept. Um, so as Stephen very rightly said, there is a collateral sort of damage or impact of COVID. I mean, you have the cases, you have the deaths. I mean, as of today, we have 74 million cases and 1.6 million deaths. but and these are massive casualties. Um, but we also at the same time are seeing a lot of indirect health effects of COVID, and massive disruptions with respect to sexual and reproductive health, with respect to child health, infectious diseases, and non-communicable diseases. I think UNFPA has estimated that around 47 million women will not be able to access essential contraceptive services. There may be 7 million, up to 7 million unintended pregnancies. Um, and just the other day, I would like to actually use some of the anecdotal data that Sabina shared with us, that pregnant women are because of the fear of COVID, they are not seeking regular healthcare. So there has been a decline in antenatal care services. We are seeing a rise in home deliveries, and we're also seeing a decline in postnatal care. So at the community level, community health workers that have been deployed for COVID-related contact tracing work are not able to provide these services. Then vaccinations, child health vaccinations have dropped. Also, in terms of infectious disease, detection of TB has declined because technological resources and finances have been diverted to COVID. And even in terms of screenings, appointments, and treatments for non-communicable diseases like cancer, asthma, chronic obstructive pulmonary disease, they have all declined. And these health effects, indirect health effects, have been witnessed across the board, not just in low and middle income countries. We're also seeing these disruptions in richer countries. We're seeing them in UK, in European countries. Just to give you a quick snapshot, so these are figures from the Ministry of Health in India, and this is utilization of sexual and reproductive health services, and you can see the decline in just a matter of 1 month, from February 2020 to March 2020. There's been a decline of 19% in new cases of pregnant women with hypertension. Similarly, the figures are here. I'm not going to go through these, but you can see at every health service, we are seeing a decline just in a matter of 1 month, and we still don't have a systematic view of this impact. So the point over here is that both rich and poor countries are struggling in terms of managing essential health services. And this really highlights the lack of resilience of the health system. And what do we mean by resilience? Now, it's not a new concept. It's been most recently, it's been widely discussed post Ebola, and it has been defined as the capacity of health actors, institutions, and populations to prepare for and effectively respond to crises, to maintain core functions when a crisis hits, and be informed by the lessons learned during the crisis and organize the conditions that require it. So essentially, a resilient health system is one that is able to function even during a shock, even during everyday changes. It's able to manage its essential services. So what I'm going to do in the next 5-6 minutes or so, based on the country cases that we've studied at the University of Edinburgh, I'm going to sort of unpack 5 features of resilient health systems, of how some countries have actually been successful in responding to COVID by demonstrating these features of a resilient health system. So Sabina, I'd just like to tell you, if you can just remind me of the time if I go overboard.
Yeah, sure.
Thank you. So the first feature is being vigilant. Vigilant, I mean, it refers to surveillance. So really being on top of the kind of outbreaks, the kind of, whatever is these kind of outbreaks that are ongoing within one's region, outside one's region. So I'll give you the example of Taiwan. the WHO was notified about a cluster of cases of pneumonia on the 31st of December, and immediately on the 1st of January, Taiwan started screening flights, incoming flights from Wuhan. And on the 12th of January, the Ministry of Health sent a team to China to investigate. They came back, and within a week, there was a national command center set up. So this really demonstrates the importance of constant surveillance. The second feature of a resilient health system is being responsive, is being prepared, is responding early. Now, and over here, South Korea really sort of leads the way, and they have not just been preparing for it this year or last year. They've been preparing for such kind of a situation since 2015. Now, in 2015, South Korea suffered an outbreak of MERS, and since then, they've invested massively in preparing standard operating procedures that have been given to hospitals to act in a certain way when such a situation happens. They invested massively in their biomedical industry, which meant that in January itself, these industries that received previous financing were able to roll out their own tests, rapid diagnostic tests. And because South Korea had their own local diagnostic test in early February, they rolled out mass testing campaigns across the country where they were testing symptomatic and asymptomatic individuals. So they were able to sort of capture the cases right at the community level before overburdening hospitals. A health system has to be flexible and adaptive. Now, this is a picture of the Fangkang shelter hospitals in China. So when there was no space for patients in the hospitals, massive open air venues or massive venues like this stadium were converted into sort of treatment centers for patients with mild or moderate symptoms. Now, many countries have done this, and this is just an example of how such measures have to be put into action in order to sort of manage the health system. The fourth sort of aspect is community engagement. Now, a health system is only as resilient as its local communities. So, at the district level, at the state level, there has to be a link with the local communities, with the leaders, with people. So, here we have a fantastic example from the state of Kerala in India. So, Kerala really performed much better than its neighboring states in India. And it was able to do so in part because of the active community participation. So we can see here that there were almost 300,000 youth volunteers who were trained by the state government, and they were supporting the police and the health teams in contact tracing, in monitoring isolation, and supporting vulnerable families with food or with any kind of other services that were required. Finally, a resilient health system has to be equitable. It has to take care of the health costs, especially for the most vulnerable people. Imagine, I mean, if, for instance, COVID tests, one has to pay for COVID tests, if one has to pay for a bed in a hospital, then this is going to dissuade people who are symptomatic from actually going and seeking care. And this has massive impacts, not just for the individual, but for their family and for the society in terms of transmission. So Thailand really has led the way here. They started the universal health coverage campaign way back in 2005, and the country is reaping its benefits now. And we've seen that it has low number of cases. Also, in terms of the indirect health impacts, it's not that high, so it's managing well. So I would just like to sort of sum up and I know Gabriel, who will come next, will just expand a little more on this aspect of equity and universal health coverage probably. But these countries or these provinces or even cities have really shown that they have demonstrated these aspects of resilience. So I think moving forward, we really need to sort of focus on building resilient health systems. And it's not going to be easy. It's not going to be, in fact, I have kept a question here. um, you know when we present this framework, we're often asked, okay, how are you going to finance this? You need a lot of investments, and it is going to be difficult, especially right now when the country's resources are being diverted towards COVID response, towards vaccine purchase and procurement. But there are innovative ways of financing, and if people are keen, we can discuss that later during the discussion. So thank you very much.
Thank you so much, Genevieve, for highlighting the features on health system resilience and sharing the examples of different countries. So with this, we'll move on to our third presentation from Gabriel Coder. Gabriel is a development economist researching, publishing, and advocating for rights-based research policy approaches. A UN officials for almost 3 decades. He worked at UNESCAP, UNCTAD, UNDP, and UNICEF. She is affiliated with UNRISD and teaches in university programs related to SDGs, and social protection. She is a board member of WECF. Recent publication into the politics of social inclusion, bridging knowledge and policies towards social changes. So over to you, Gabriel. Thank you.
Thank you so much, Sabina, and thank you to Sabina and Deepak for organizing this whole series. I've looked at a lot of your seminars and find them very enlightening to understand what the situation is around the world. And thank you to my two pre-panelists. I think we follow upon each other very nicely, and very nice of so many of you to be listening in. Can you see my screen, my presentation?
Yes,
Yes.
yes, we can.
Yes. Okay, so what I'd like to talk about follows exactly on what Stephen and Genevieve have been saying, these compounded inequities that we're seeing in health systems and some of the equity issues that surround this. So just in a different way of what Stephen has already pointed out, who is affected. I want to do three things, sorry. I want to look at who is affected, what is happening, and what do we want. So in terms of who is affected, we see these two layers, right? Or what Stephen said, sort of what, do no harm and be careful of the secondary impact of the measures taken in response to the pandemic. But directly the pandemic, of course, as we've already seen in Stephen's slides, it affects, and in Genevieve's presentation, it affects persons with vulnerable health conditions, both those who are elderly and more vulnerable or more susceptible to actually succumbing to the virus, but also other people with other conditions, other health conditions that are now either not seeking or not receiving the health services that they ought to be receiving. Health service professionals, in the very beginning of the pandemic, very many health service professionals, doctors and nurses actually died of the pandemic, of the virus, because they weren't sufficiently protected, or because one wasn't quite sure about this aerosol transmission. Affected very much, of course, are the key workers, both in the hospitals, the support staff, but also retail workers, people in factories who are affected by the production and have an impact from this kind of pandemic situation. Everyone who is in a socially excluded community, marginalized people who might have difficulties, face stigma when they seek health treatment, and then in general, everyone facing or living in systems that are under-equipped, that are not resilient, as Genevieve would put it. And then we have all the secondary impacts, and as Stephen pointed out, millions of people will additionally be falling back into hunger and severe poverty, where there had been some progress in recent decades. So if we look at the secondary impact, we see it's precarious workers. I'll say a bit more about that in a moment, but roughly 3 billion people work in situations where they are not in contractual arrangements. They don't have employment insurance, assurance, nor insurance. Of these, 1.6 billion people are directly now affected by the lockdowns and the different strategies undertaken by governments in reaction to the pandemic, or reactions taken by businesses where supply chains are now being disrupted, orders are being cancelled, and people are being laid off. migrant workers, both in the sense that the lockdowns are affecting them, and then, as Stephen pointed out, because they live in very tight accommodation. And in addition, the people who are receiving the remittances from the migrants are now not receiving these remittances because the migrants have lost their sources of income. Asylum seekers who live again in very unfavorable kinds of living conditions. And then again, the group of socially excluded communities who tend to be in remote areas, who tend to be in slums, who tend to be in high-rise buildings and have very difficult living circumstances. Prisoners, the same kind of situation, much too, I mean, apart from other political issues, much unfavorable living conditions. And then we have another group of people who suffer very much from this secondary impact level. First of all of the providers of unpaid care, all the care workers, meaning women mainly, who care for their families, who do the housework, who do the childcare, the elderly care, the care of sick people in the family in an unpaid fashion, who deliver 3 hours per day on statistical average more work than men, and so are already in a vulnerable situation in terms of their own personal resilience, and have now additional work because of the pandemic. Violence against women has increased in very many settings because of lockdowns and people being locked in together with their oppressor. Children very much affected. Stephen already mentioned out of school children, very differently affected if depending on how the household is equipped with alternative means of learning. And then again, everyone who's living in a weak welfare state where the system is just not in a position to support people. Just one way of looking at the differential impact by social exclusion. This is something on the UK, mortality differences. It's done here by ethnicity, with the finding that Black men and women actually are 4.3 and 4.2 times more likely to die from coronavirus. And I would argue this is not related to ethnicity per se, but it is related to the living conditions in which people of color tend to live, to the work conditions, and to their overall situations of also being under a lot of stress as a visible minority. So in a way, one can say who is affected: people by gender, women more than men; people by age, old people and children more than others; and people who are socially excluded. And when we look at it, not just at the individual level, but at the structural level, people who are in vulnerable employment and hence face income poverty, poor housing, poor access to nutritious food, etc. On vulnerable employment, just a statistic to show what I mean: vulnerable employment is any kind of informal sector job where people don't have a contract, as I mentioned, where they don't have social security, social protection. And we see that in Southern Asia and in Sub-Saharan Africa, 60% and more of women and men are actually in this unfavorable, indecent, vulnerable employment situation, and very high levels across the globe. So any person in this kind of working condition, when then a pandemic hits and destabilizes an economy, a society, a community, are particularly vulnerable. So what is happening? First of all, on the status quo before the pandemic hit, only less than half, only 45% of the world population are actually covered by any form of social protection, meaning any measure, any policy measure to which they can resort to get income support, to get food support, to get employment, unemployment benefits, etc. Only half of the population. And this refers to just one kind of social protection transfer, such as a child benefit or a pension or an accident insurance. But what has been happening now since February of this year, when the pandemic became visible, just like we've seen exponential growth in the affected people, in the transmission, we see exponential growth in the number of policy measures that have been adopted. We see a veritable surge in social transfers, 1,500 new measures adopted just between February and October of this year. Now, that of course is a good thing, in the sense that we see something happening on social protection. Excuse me. However, the surge is a good thing, but the social transfers are all of short duration, 3 months, 6 months, some are being extended, some are not. The transfer amounts are very small. In Germany, for instance, there's a sort of a furlough scheme whereby people receive 60% of their former wage. But if you're already on a very low wage, 60% of that low wage is extremely little. The informal economy, all these people in the vulnerable work kind of situations, are vastly undercovered. In fact, the pandemic has revealed or made, hasn't revealed, we knew this before, but has made more visible how many people, in the working age group, 15 to 60, let's say, are not covered by any kind of social insurance, social assistance, social support. And then a very interesting finding relating back to the surge that we saw is that WIEGO, a feminist organization, did a survey in 10 cities across the world where the government had been reporting a lot of social protection, these 1,500 new measures, as it were, reporting about them, but then half the workers whom they interviewed actually hadn't seen any of this money coming into this household or any of these food supplies becoming accessible. So we have a bit of a discrepancy in the reporting and in the actual policy rollout. Again, surge is good, but rich nations are spending much more, incomparably more than poor nations, almost $10 trillion spent in the global north versus 42 billion in the global south, or broken down to the individual. In a different survey, 28 rich countries are spending on average roughly $700 US per person, whereas in 42 other countries, lower middle income countries, it's only $4 to $28, so far less. So we can see that the surge, as I said, is a good thing, but it's actually not at all sufficient to address the secondary effect of the pandemic. And then, of course, everyone will be looking at who is now getting the vaccines, because we see the first vaccine rollouts in the UK and Canada, and I think also in the US now. But if we look at this process for the next few years, we see, again, an entirely inequitable situation where the access to the coronavirus vaccines is very, very uneven. The dark green and the light green are the countries that will be, or where people in the countries will be receiving, will be vaccinated in the foreseeable future. And the dark red and the pink is where this will not happen until 2022, 2023. So again, a huge inequity. And of course, there's big debates about how do we assure access to this vaccine for everyone on our planet. So what do we want? There's a universal right to health services, access to health services. There's a universal right to social protection. It's been there since 1948 with the Universal Declaration of Human Rights adopted by the United Nations. And there's a covenant on economic, social, and cultural rights, which was adopted in the 1960s. And there are all these conventions, such as the Convention on the Rights of the Child and the Convention on the Rights of Women, which actually promise access to health, access to social protection. We then have the SDGs, which I'm sure everyone is familiar with, and 5 of the 17 SDGs explicitly relate to either social protection or to decent work. My point about the knock-on effects of how the pandemic related policies are affecting people. And they also, one of the SDGs, the one on gender equality, also speaks to unpaid care and domestic work, and how to have social protection measures put in place to support women in this difficult situation. So we have the means in terms of the normative level, promising commitments, promising to deliver on universal social protection, on universal health coverage. It's often even abbreviated as UHC, but we are far from being there. And so what do we want? We obviously all want to overcome these compounded inequities. So we need integrated, well-funded health systems Genevieve would call it resilient health systems. I completely agree. And universal unconditional social protection. And the important point about the resilience is really about having this surge capacity for disasters, for pandemics. And it was interesting to see how Taiwan and South Korea actually have been instituting this, for decades now. To show that one has to be prepared and one has to have this surge capacity for difficult circumstances, so that people with the other vulnerable health conditions are not crowded out when the health system is then sort of concentrating on pandemic or disaster relief patients. We need welfare states which have a strong element of redistribution. Genevieve was saying, how do we finance this? And I could say a bit more about that maybe in the discussion. They need to be redistributive in the sense that there has to be progressive taxation to fund this resilient health system and universal social protection. We very importantly need to look at social inclusion in the sense of agency, that to hear the voices of those who are socially excluded. What exactly is it? How exactly would they like the government resources to be spent? How do we ensure equity? And then how do we have equitable access and coverage? To reach that, I would argue that we need parliaments to really be functioning, to not be corrupt, to be really listening to their electorate and to migrants in the country and asylum seekers who are in the country, and cater to their rights. And at the same time, I think civil society is extremely, extremely, extremely important. For all of us, it is important to know what our rights are, to know what what the Bill of Rights has been promising us for 70 years, to claim those rights and then to monitor on the delivery. Remember that, this point about government saying they're rolling out, at the global level, 1,500 measures. And then if you go and look at the local level, you find, well, many people are actually not recipients of these policy measures, of these social transfers in this case. We need social justice within each country and amongst all the countries. We saw this huge inequality in terms of the access to the vaccine, and much more so even in social assistance and in health systems. And for that, we need global policy coherence. And there, I can very briefly just say what I mean by that in terms of what's the financing side to this kind of a properly functioning, socially just, gender just, climate just welfare state. It needs the funding, the financing. So we need to do away with tax havens. We need to have tax transparency. We have to have debt cancellation. We have to get away from austerity policies, which have been hollowing out health systems and social protection systems for decades now. We need different kinds of trade agreements, and we need a regulation of global supply chains so that we actually have decent work, and the millions, billions of people working in undecent work, in vulnerable work, actually are given decent jobs for social protection. So that's part of this global policy coherence that is needed if we want to have proper, strong welfare states that really deliver to the people. So we need to overcome these compounded inequities. And my final point is really that horrible, dismaying, saddening as this pandemic has been, this surge in social protection and this new awareness of the lacunae in health systems, I think it is has one good side effect, one single good side effect, which is to make people in the policy realm, in academia, in the UN institutions, in global institutions, aware that something has to change in the system, and that we have to move away from these very unequal kinds of global and national level arrangements and come to a different kind of system that overcomes these compounded inequities. Thank you very much.
Thank you so much, Gabriel, for highlighting on the social protection measures, universal health coverage, and overall compounded inequalities that existed during this COVID-19 pandemic. So, with this, we are at the we have ended all the three presentations from all our three presenters. I'd like to thank all the three presenters for their excellent presentation and providing insights on the different aspects of health system and equity issues in context of COVID-19. Yes, this COVID With this, we'll move on to the Q&A and discussion session. So far, we have only one question received from the participant. I request the participants, if they have any questions for any of the speaker, please kindly leave it in the chat box. We'll address it. Um, I would like to start the discussion with one question. It's that because of the current pandemic situation, even the robust health system has been overwhelmed and compromised. So, in this context, I would like to ask, what are the major weaknesses within the health system that COVID-19 brought into the forefront? So, maybe we could start with any of the speaker, maybe Stephen or Genevieve.
Um, yeah, so I mean, between countries, even countries at the same economic level, like there is considerable difference in how robust health systems are. My big focus is on primary health care services, although clearly in a situation with COVID, there's been big preoccupation with critical care. So managing like severe cases of COVID. Um, Certainly it's the case in low-income countries, low-middle-income countries, that the existing capacity for ICU care, for intensive care, like it's substantially less than it is in higher income countries. Now, fortunately, in almost all of the lower income countries in sub-Saharan Africa and South Asia, that the actual burden of severe COVID cases has been substantially smaller than in high income countries. Now that's countrywide, but obviously in certain cities at certain times, the capacity for critical care has been overwhelmed. So even in these lower income country settings where there hasn't been as great a COVID burden. I think at the end of the day, if you look at population health in general, primary health care services contribute substantially more than tertiary level or critical care. And I think as Genevieve was pointing out, what's happened through this period has highlighted the relative lack of resilience in those primary care services. And I think it's a matter of tremendous urgency that we get those basic primary care services functional, and we reduce the barriers to access. So there's both supply side and demand side things that need to be done. But I mean, just for example, immunization services for routine immunizations, like as those services are interrupted and as coverage declines, I mean, there's every reason to believe that we're going to have massive measles outbreaks this coming year. So there are effective interventions that we've deployed in the past at high coverage, and we've allowed that to slip. So that's that's been one of my big preoccupations.
Thank you.
Just
Stephen,
to just to add to what Stephen has said, many of the countries in South Asia, for example, have a very wide primary healthcare infrastructure. There are healthcare clinics in every block, but these are massively underfunded, understaffed. So really, there's a need to reinvest and strengthen the existing infrastructure. The second thing is obviously strengthening the surge capacity at the secondary and tertiary hospitals. Another aspect in many countries in Africa, even in South Asia, is this synergy between public and private healthcare. Because in India, for example, I mean, the private healthcare system provides health services for a big chunk of the population. And in many states, we are right now seeing battles between private hospitals and public hospitals in terms of allotting beds for COVID. So private hospitals are even going to the Supreme Court and saying, listen, I'm not getting my profit, so I cannot allot all my beds for COVID. So these tensions really need to be sort of really discussed when we're talking about moving ahead and building the capacity for post COVID or even now. Over.
is there anything from Gabriel to add on to these points? You are muted, Gabriel. Please unmute yourself.
I'm sorry. I think this point about public and private sector delivery of health is one of the key questions. And if we go back to this Universal Declaration of Human Rights, or if we go to the SDGs, it's about universal health coverage. And if we see health as a human right, it can't really be something that's paid for at point of delivery. I mean, obviously it has to be funded in some fashion, but this has to be funded from a tax system or from an insurance system that then looks at the different health burdens and, you know, evens out by income group. If that's not the case, and if one increasingly resorts to private delivery of health services, we will have more and more of this inequitable divide between higher income and lower income groups. I have, you know, I sort of picture this statistic I know quite well from Myanmar, where it's about assisted delivery at birth. As you probably all know, 300,000 women continue to die in childbirth every year. No one puts that on the cover of The Economist. And the rates of skilled attendance at birth delivery is 100% different between the lowest income group, the lowest 20% of the income group, the lowest quintile, and the highest income quintile. This is a statistic on Myanmar, and you can find this from many other countries as well. So again, that shows sort of this private-public kind of division, because I'm assuming that some of the people in the highest income quintile probably can pay for the health service of being assisted when they deliver a child. But the other part that I think is also important, and I'm very awed by the Thai, the Kerala, the Korea, and other models where there's this very strong emphasis at the community level of training up people to do the pre-screening, perhaps as a lay person, not a health person would call it, excellent. But one point that I think is very important, because almost all our societies, I think, are characterized by social exclusion processes. And even those systems that have, you know, a good public health, or, you know, public health delivery mechanics, people who are from a socially excluded group because they are any kind of minority, a visible minority or a sexual minority or an income minority, they get discriminated against when they seek health services. And this also needs to be addressed. And that's not just a question of, you know, the health service volume, if you will, but it's also about the quality. And getting in a caste system, for instance, so-called upper caste doctors to treat a so-called lower caste person with the same dignity and with the same resources as everyone else. I think that's also an enormous challenge that still needs to be, that we need to talk about, and that needs to be addressed. Thank you.
Thank you so much. So we have heard of recent announcement in COVID-19 vaccine development. So here is the question related to vaccine. So one of the participants asks that, what do you think about vaccine nationalism, as it is called, the role of COVAX, and what our advocacy messages to leaders in the global north should be? Any of the panelists is welcome to answer these questions. The floor is open to all the three panelists.
I mean, in principle, the existence of the COVAX mechanism is a very good thing. And there's certainly been a number of quite prominent global leaders that have been speaking out for the need to mobilize the necessary resources. At the same time, recent articles that I've seen projecting when different regions are likely to receive vaccine, I mean, they show, for example, Sub-Saharan Africa and South Asia, like not getting fully vaccinated for several years. And to me, I find it kind of fundamentally morally unacceptable that we have a queuing arrangement where the rich are at the front of the line and the poor are at the back. So I think even if the rich countries are willing to commit maybe a few $1 billion for this COVAX mechanism, it looks like they're still insisting that their citizens are at the front of the queue.
Yeah, I think there was a very good New York Times article yesterday or today morning, I don't know which one, and they have a very fantastic graph with all the countries, rich and poor countries, and the percent of population for which each country has already purchased vaccines. And there are some high income countries that have purchased maybe 5, 6 times more for their populations, including the double doses. And some countries will just not be able to afford vaccines even for 20-30% of their population. So there has to be cooperation. Secondly, I would like to draw back to Stephen's point about strategic response. One has to be strategic. So for a country like India, 1.3 billion people, I mean, procuring the vaccines is one thing with the money. Of course, we can gather money from places. We've got like 2 or 3 of the richest men in the world in our own country, but delivering it is going to be a problem. It's going to be a huge challenge. So we really need to understand, while we're procuring vaccines, we need to understand the immunity. We need to understand how the vaccine is moving in every country and what needs to be done. What other things can be done in order to boost the vaccine response, to supplement it, so to say.
Let me add there, I showed you that map of, how long it's going to take in the different regions to just have access to the vaccine. The UN Secretary General already in March or April actually started this appeal for this COVAX fund, asking especially the rich countries to pay into it, and at the same time to really declare the vaccine a public good, a global public good, a public good being something, maybe not everyone is an economist here, a public good is something that's delivered from tax money to everyone. And so everyone has a right, so everyone has to have access to this particular, in this case, this vaccine. So it has to be free at point of delivery. This fund is totally underfunded to this point, and as Genevieve is saying, some countries have 3 or 4 times the number of doses they need to get everyone over inoculated, and these countries are in the global north, and it is just abhorrent. It cries, it's unacceptable. It's a scandal. It's a scandal. So I think all of us in this webinar, for instance, need to do our share. I'm also an activist, right into the parliamentarians, right into the G7, the G20, to the millionaires and billionaires of this world, and say this fund has to be funded. I can't remember the amount that's needed for every person on the planet to pay for the vaccine for everyone. There is an interesting point that the vaccine developed in Oxford with AstraZeneca is being actually produced in India. I forget the name of the institution, a very famous
Serum Institute.
Yeah. So that's a good effort. And one point about this COVAX, one part is about getting the vaccine delivered to everyone. Second point is Genevieve's point about how do you actually get it transported to all the locations and have the vaccination facilities and the doctors and nurses, or I guess volunteers if they can, to do the inoculations. But the other point is about the TRIPS agreement, the trade agreement on intellectual property rights. There is actually a clause that in a pandemic, medication, pharmaceutical products have to be, again, a global public good in the sense that the patent, the payments for the patent have to be waived, so that any country can produce the generic version of that drug. But for some reason, which I don't quite yet understand, this is not being applied now for the COVID vaccines. And again, that's a scandal, because all of the companies that so far have developed a vaccine receive huge public funding, huge tax monies to actually do the research, which is a good thing. I'm totally in favor of it. But if a research effort is publicly funded, then it also has to be, the finding has to be made publicly available. I think that's a no-brainer in a way. Thank you.
I'd just like to add 2 more points very quickly. While we're talking about the whole delivery, there's also an aspect of demand generation. We need to really look at a proportion of population that is hesitant, that is skeptical, that does not have access, because we can bring in all the vaccines we want, but if we cannot get the population to come and get vaccinated, that's a huge challenge. And secondly, just another thing a question I'd like to throw, right now for global travel, countries are expecting international travelers to have RT-PCR tests done. Is vaccine going to be a criteria in the future for travel? And is that ethically correct or not? So that's another question I'd like to throw up to the participants to keep thinking, because this could be the reality, where a country says, well, you need to show me your vaccination form. And many countries, like in India, we will not have it for a long time. So then will that block opportunities and travel and migration? That's another question that comes in this whole sphere of vaccine nationalism. Over.
I think that's an extremely interesting point, because it sort of brings the climate footprint kind of discussion together with the health access, equitable health access discussion. And you probably all are aware of the statistic that 10%, 90% of global footprint with CO2 emissions is produced by the 10% wealthiest of the world population, in terms of several factors, but including because of air mileage, air travel. And so if then to travel on a plane, you need to be vaccinated, so you need to have some way of getting the vaccine and getting your folder to document that. And then you are part of the global jet set, as it were. I confess that I also fly a lot. Then you have this double whammy, as it were, of again the social exclusion and inequity processes being compounded yet in another way.
That's a really nice discussion, and we need to ensure the equitable vaccine distribution in the poor countries and among the poorest people and vulnerable people. That's very important. So I also would like to ask one question, like COVID has been a global challenge. So what could be the major lesson learned for the global community to tackle this sort of pandemic in near future? So what's your point of view on this? So maybe Stephen could start.
Well, I think all that we've been discussing here are sort of bits and pieces of the big response, right? I mean, just as Stephen said, for example, a strategic response. We need cooperation. We need funding of the WHO for starters. I mean, we saw that President Trump sort of decided to pull off funding from the WHO, and we're hoping that the president-elect of the US, Joe Biden, will then reinstate. And then we need members to increase investment for multilateral cooperation. And then again, on various fronts, so, and then increase investments for public health system plus social protection. So these are the big sort of things we need in order to start recovering from the massive impact of the pandemic.
What I think, what I think is interesting, as I mentioned, this surge, this increase in social protection, which for decades was sort of the hobby horse of some policy advocates and activists, and it's now many people are speaking of a cultural shift. For instance, there's been a lot of resistance against social transfers for poor people, because there's this notion poor people are poor because they don't work hard. Whereas you saw the slide on the statistic on vulnerable work, people are poor because their work conditions are underpaid, overworked, informal economy, no health insurance, no maternity leave, etc. So maybe this surge in the social protection movement, as it were, will also have knock-on effects on saying, in general, we need a very different kind of welfare state kind of arrangement with resilient public health, well-funded, and then also hopefully a mindset shift in terms of global policy. And so, as you're saying, WHO needs to be funded in a much different way. The UN as a whole needs to be funded in a different way. And maybe also to refer, the United Nations has these different disaster funds, which were, some of them were created not that long ago, maybe 2015, if I'm not mistaken, including for pandemic relief and disaster relief, earthquakes, pandemics, etc., which are totally underfunded. And I think we need to raise the visibility of these kinds of arrangements, which for the lower income countries can then kick in and help in the public in the public domain to co-finance the measures that are needed. And I think the third point is really about doing away with austerity politics. I mean, we've seen in basically every single country of the world how over the past, since the 1980s, there's been this notion that you need a small government that doesn't interfere too much. And public health services have been downsized, hospital bed numbers have been downsized. The same applies to education and water and sanitation, and all the other areas that are extremely important for health. So the funding is not there. And what is also a cultural shift at the moment, and we have to be very, very attentive for it to not be stolen again, is that at the moment, governments are actually overriding this austerity thinking. The German government was obsessed with having a balanced budget, not taking on any new public debt. All of a sudden, they've seen they need to do something. They need to, go away from this balanced budget and actually do a lot of deficit spending in order to address the pandemic itself, plus the fallout, the knock-on effects, the collateral harm, as you were calling it. And so I think we have to really make a move for austerity politics to be over. It's no more acceptable. And we see in such kind of crisis situations that have affected the whole world, that something needs to change also in terms of how government policy is shaped and how fiscal policy is done.
Yeah, I mean, I would hope that, let's say 5 to 10 years from now, looking back on this period, that we would see that what we've experienced during this period has cast inequities in a very stark light, and that during this period, again, looking back, that we'll recognize that this was a time when we really saw how bad things are with regard to inequities, and we saw a deterioration, and that recognizing that would galvanize, I would say, a kind of a moral, political kind of understanding that we need to kind of organize our collective life differently. So I think over the shorter term, things may get worse with regard to inequities, but my hope is that over the longer term, that this is going to contribute to the development of a powerful, world-spanning social movement saying, no, that's enough.
So maybe the last question to Gabriel. So I saw in your slides, it's global policy coherence. So I request you to explain a bit and make it quite short. And with this, we'll end this discussion session.
Thank you, Sabina. What I mean by policy coherence, here we're focusing on health and on social protection, and in a way those are national level policies, when we need support from the outside in some cases, but basically it's about national policy thinking and having the surge capacity, having resilient public health systems. But it all hangs together, and with globalization and with migration, for example, there's so much exploitation happening. So if we don't regulate, for instance, these global migration chains, these global supply chains, and ensure that there's decent work, we will continue having a very inequitable starting point. So we need a binding treaty on business and human rights. We need to have tax income in all countries. There's so much tax evasion, so we need a global tax body. Presumably at the UN level would be a good place to have it, so that all countries would be in this effort to look at where is tax evasion happening, where are countries shopping, or where are companies shopping around for the most advantageous tax location. It's not necessarily tax evasion, but it's sort of tax shopping. And to stop that, we need to have capital, a control of capital flight. So many lower income countries and higher income countries are hemorrhaging. The fiscal budget is hemorrhaging because of capital flight. We need these trade agreements to change. We need to have forms of international trade agreements that actually benefit the lower income countries. We maybe need to go back to something like industrial policy, which used to be fashionable and now only very few countries talk about, enabling countries to raise their productivity. And what I mean by saying that this belongs together, if we only fix or if we only advocate for a good, resilient public health system without seeing, as Genevieve was already pointing out, how is it funded, we're missing part of the equation. If we're not looking at how to create decent work for everyone, remember the 1 million people in women, I think it's 1 million in Bangladesh who lost their jobs because the global business buyers in the rich countries just canceled their contracts, and these women had no form of social protection, let alone any savings to fall back upon. This has to stop, and there has to be decent work. And then if we see all of these policies together, and also if my plea is a bit that all of us activists get together on these different topics and move together, for a binding treaty on human rights, for resilient public health services, etc., then we would, I think, be more effective, because we all tend to be in these parallel processes, and often the connection between all of them is not, we know it, but we don't quite get there in working together to actually achieve a change of the system.
In fact, I mean, that's really the biggest thing that the pandemic has highlighted, right? The whole systemic nature of the problem. You cannot just look at it as a health problem. It's a social problem. It's an economic problem. It's national, global. So there has to be sort of syndemic, systemic work. You cannot just look at Ministry of Health alone.
So is there anything to add from Stephen?
May I just add one more point on WHO? For years, there's been an effort to have some kind of global taxation on airline miles or on global carbon emissions, and to use that tax income to fund UN agencies, for instance, the WHO or the UN as a whole. Because the way the funding works is that the countries are contributing based on an assessment of their GDP and their population size, I believe, but that makes for a very unbalanced situation. If we had global finance coming into these UN agencies or into these special funds to address pandemics, as an example, they would be much more independent of big players. The US, for instance, is the largest funder of the UN system. So when they pull out of an agency, they're the largest funder because of their GDP. If they pull out of an agency, a quarter of the revenue is gone. That's it's like catastrophic health spending. It's a catastrophe for the agency. So we also need to think about, the global funding of global institutions and how, because that would then again help for health funding and health systems and resilience.
Thank you so much, Gabriel. So we really had a nice discussion about health system and inequalities and all those things. So I thank all the speakers, Dr. Stephen, Dr. Genevieve, and Gabriel, for their time and effort you took in presenting your insights and experiences among our audiences. So thank you so much. With this, we are at the end of this webinar. I also take this opportunity to thank CIH One Health Knowledge Cafe for organizing this webinar. This has really been interesting, and this is the last webinar for the year 2020. Hope we will be able to organize this sort of webinar in 2021 as well. So with this, I officially would like to announce the end of this webinar. Thank you so much. Have a good time. Stay safe. Thank you so much.
Thank you so much.
Thank you, everyone. Thank you. Stay safe, everyone. Bye-bye.
Stay well. Bye-bye. Thank you, Sabina.
Thank you.
Bye.
Thank you.